This is a 33-year-old lady, a patient who had a soft tissue sarcoma over the forearm. She had a wide excision done. This was after the wide excision. 12 months later, she developed a lesion which was involving the left 10th rib, the liver, the spine. She had a wide excision done of the 10th rib. She then took 6 cycles of chemotherapy. 6 months later, she now had pain in the mid-back. This time it was severe pain radiating along the chest wall. There was tenderness at D7-8. Power was normal in the legs, but she did have some upper motor neuron signs. This was the MRI picture at that time. You can see there is a lesion which is involving the posterior half of the D7 vertebra, which was invading the epidural space and causing some early neurological compression. At that stage, I had this opportunity. This was a patient who had a soft tissue sarcoma, which is a radio-resistant, chemo-resistant tumor, to do something. And I went in and did a transpedicular decompression and stabilization, and this was followed up with a conventional external beam radiotherapy. The patient did well. She recovered very well and was mobilizing well. 12 months later, she came back with paraparesis. And this was the picture. The lesion within the vertebral body had increased. There was again severe cord compression. I went in again, and this time from the front through a transthoracic approach, did a corpectomy, decompressed the cord, and stabilized the whole thing. The patient again went on to do very well, recovered neurologically, and went home. Only returned to me 3 months later with paraparesis again, a large mass encircling the spinal cord. Again, I went through a repeat decompression. This went on a couple of times more, at the end of which she gave up. I also thankfully said that she went away. I heard that she was later admitted in a hospice in Bangalore, where she died a miserable death 1 year later from paraplegia secondary to this tumor. What I wanted to make a point is that spine metastasis represents the end stage or the last stage of primary cancer, where their patient's tumor has metastatized to multiple levels. The survival year ranges from a few months to a few years. The goal of treatment is very clear. It is either short-term or long-term palliation. It is not curative. And what does palliation mean? Palliation means to enhance the quality of the remaining life of this patient by limiting the systemic spread of the tumor, by achieving local control of the spinal metastasis, and relieving pain, preventing or reversing neurologic deficit, and preventing or restoring function. The optimum treatment strategy must achieve palliation with minimum morbidity and complications. And whatever treatment you do must last for the patient's duration of the patient's survival. If the treatment that you do ends up in the patient having to spend a majority of time in and out of the hospital, then you have not done any favors for this patient. And that is what this case exactly made me feel. I felt so helpless at the end of that procedure that I had actually made this patient's life far more miserable than if we had not done anything at all. What I am going to take you through is an algorithm for decision making in spinal metastatic tumors. The first step in the management is always the assessment of a patient. The assessment, of course, is based on history, examination, and all the various investigations that one does in order to diagnose the tumor, to prognosticate the survival, and to plan your treatment. But the Sloan Kettering Memorial Hospital has come up with its own framework for assessment of patients, which is called as the NORMS framework. The NORMS framework is divided into 4 parts: neurologic assessment of the patient, oncologic assessment, assessment of the mechanical instability, and systemic assessment of the patient. Why neurologic assessment is important? About 5 to 10% of patients with spinal metastasis present with epidural spinal cord compression. The neurologic status determines the functional status of the patient. it determines the quality of life, it determines the overall survival of patients and the risk of postoperative complications. In fact, in patients with myelopathic symptoms, life expectancy is supposed to be less than 7 months. Neurologic assessment is based on two things: the clinical neurological examination to find out what is the severity of the neurologic deficit, and the second is an MRI assessment of the amount of epidural spinal cord compression, which is seen on an axial T2 weighted image. Grade 0 is no epidural spinal cord compression. Grade 1 means mild epidural spinal cord compression. Grade 2 and 3 means moderate to severe cord compression. The second assessment is an oncologic assessment. Here you want to find out what is the primary tumor from which this metastasis has originated. What you want to find out is what is the amount of systemic spread of this tumor, because it is necessary to stage the disease and to estimate the survival of the patient. And you want to get a knowledge regarding the tumor because you want to plan the treatment. Today there are biomarkers available for the tumors. And these biomarkers, if they are present, tell you that this tumor may be sensitive to modern systemic therapies like immunotherapy, etc. And therefore, the patient may survive much longer. A classic example being Sanjay Dutt, who has a lung cancer, but he's surviving fairly well because he is sensitive to chemotherapy, to the modern immunotherapy drugs. The third assessment is mechanical instability. This is vital because this is what, as spine surgeons, we primarily treat. In the past, the definition of instability was very nebulous. If we felt, oh, patient has some mechanical symptoms, there is instability, let's operate. But now, the spine tumor study group has come up with a very clear scoring system called as the SINS scoring system. It is based on the location of the tumor, the pain that the patient has, the bony lesion, whether it is lytic, mixed or blastic, whether there is any abnormal spinal alignment, what is the amount of vertebral body involvement, and what is the amount of involvement of the posterior structures. Based on that, the mechanical stability can be graded as stable if the score is between 0 to 7, indeterminate if it is between 7 to 12, and unstable if it is 13 to 18. It has been shown that this scoring is very, very well correlated with the severity of pain, with more pain indicating a more unstable problem. The last part of your assessment is a systemic assessment, which determines the patient's ability to withstand the proposed treatment. This is based upon the frailty of the patient, the general condition, the medical comorbidities that the patient has, and the nutritional status of the patient. Based on all these assessments, one then tries to estimate the life expectancy of this patient, and for this, the score which is commonly used is the modified Tokuhashi score, which was proposed as far back as 1995. Today, with modern systemic therapies, life survival has improved significantly, and therefore the modified Tokuhashi score is not completely applicable, but it still serves as a very useful guide to, especially in our country, where a lot of patients cannot afford expensive immunotherapy and systemic drugs. So, this life expectancy score is based on Karnofsky performance status of the patient, the number of extraspinal bony mets the patient has, number of spinal metastasis the patient has, if the metastasis to major internal organs are removable or unremovable, the presence or absence of a neurologic deficit, and one of the most important things which determines the life expectancy is the primary site of cancer. If the score is less than 8, the patient's survival is likely to be less than 6 months. If the score is between 9 to 11, survival is 6 to 12 months and thereof. Now then, once we have determined these assessments, the next step is to know what are our treatment options. The treatment options can be divided into treatment options for systemic control of disease and treatment options for local control of disease. For systemic control, you have systemic therapies, and the systemic therapies now, originally it used to be only chemotherapy, which was basically a tumoricidal. It used to kill tumor cells. Today, the newer systemic therapies are all tumorostatic. None of them kill cells. They only stop the multiplication of the cells, and therefore till this tumor therapy goes on, the patient's tumor we may be able to control it. The moment you stop the drugs, the tumor will start growing again. The other things which we use for systemic control are of course steroids and bisphosphonates. The other thing which we give is for palliation, which is pain control, and for local control we have two modalities, radiotherapy and surgery, and there are some newer techniques which have come in. Surgery was the original treatment for the metastatic tumors which is causing epidural spinal cord compression. But in the good old days, the techniques did not allow stabilization, there was no posterolateral approach to the thoracic spine, so results were not very good. In the 1960s, radiotherapy came into being. Radiotherapy was fairly active, and soon it became evident that the results were not bad at all. So gradually surgery fell into disfavor. It was only in the late 1990s and early 2000 that it became evident that with modern techniques of spine surgery, followed by radiotherapy, the outcomes were far superior to radiotherapy alone or to surgery alone. And that is what is going on today. Let me give you a brief idea about the treatment options. The first of them being systemic therapy. As I said, it is meant for controlling the systemic spread of the disease. This results in overall improvement of the overall survival of the patient and the disease-free survival of the patient. And this has significant increase in overall survival has happened with the advent of newer therapies over the last 10 to 15 years. However, systemic therapies have a limited ability to achieve local control of the tumor. The effect also takes a longer time to manifest, and therefore large masses cannot be treated with systemic therapies at all. It is useful mainly in asymptomatic or minimally symptomatic spinal metastasis. The exception being hematologic malignancies like lymphoma, myeloma, which are exquisitely chemosensitive. And here the tumor resolution is far more rapid, and therefore surgery is usually unnecessary even in patients with major neurologic deficits. The second is radiation therapy. What is radiation? Radiation means an external beam or a linear accelerator is used to put in gamma rays, X-rays, and kill the tumor cells. It achieves local control of spinal metastasis by ablating the tumor. It alleviates biologic bone pain, and it relieves neural compression by shrinking the tumor. The limitations are it is not effective when the pain is a mechanical pain because of spinal instability, when there is cord compression because of an epidural spinal cord compression by bone, or it is not very effective in severe cord compressions because the effect takes longer to manifest, and again resolution of large masses may be incomplete, and therefore radiotherapy is not recommended for severe grade epidural spinal cord compression and patients who have a long duration of neurologic deficit. And therefore radiation therapy is primarily indicated for radiosensitive tumors without instability, without significant neurologic deficit or epidural spinal cord compression. There are two types of radiotherapies which are in vogue today. One is the conventional external beam radiotherapy, which uses a linear accelerator, and it used to be 2D, now it is 3D radiotherapy which is being given. This modality of radiotherapy is good for short-term palliation. Why? It does help in tumor control, but after some months the tumor starts regrowing, the pain reappears, and there is a limited ability to reverse neurologic deficits. The problem with conventional external beam is that it is not very focused beam, it is a wider beam, and therefore it has a danger of injuring structures around the bone, which is the spinal cord, the esophagus. And therefore to prevent injury to these structures, you lower the radiation dosage. And this lower dosage may be inadequate to cause tumor necrosis. And based on this, it was divided that there were tumors which were sensitive to this lower dose. They were called as radiosensitive tumors. This terminology of radiosensitivity and radioresistant is based on its sensitivity to conventional external beam radiotherapy. The other method which has come up today is stereotactic body radiotherapy. Here you are having a tightly focused beam with image guidance, IMRT, that is intensity modulated radiotherapy, is given, and this has very little spread to adjacent structures. And therefore, it allows better tumor control even at 4-year follow-up, and excellent pain relief, which is far superior to the pain relief of conventional external beam radiotherapy. It works even in radio-resistant tumors and previously radiated tumors too. The third form of treatment that we use is surgery. So why surgery? It's obvious, we use surgery because we want to control the tumor locally by resecting the tumor. This improves the overall survival of the patient. You want to control pain, which is possible in about 75 to 100% of patients with surgery. And finally, you want to improve the neurology and restore the ambulation of patients, which is one of the key things, that outcomes that is necessary. And what do you do at surgery? The first thing in surgery is, if it's a hypervascular tumor, you embolize the tumor. The second step is, you excise the tumor. Depending upon the type of tumor and the patient's survival estimate, you decide what is the type of excision you want to do. The third step is to reconstruct. Since 95 to 98% of the tumors involve the vertebral body, therefore there is a defect in the vertebra and you need to reconstruct that defect. You want to restore the spinal stiffness by stabilizing the spine. And finally, you must remember, surgery is not the end all and be all. Ultimately, you will need something locally to control this tumor, and that is radiotherapy along with systemic therapy. The first step, embolization. Why embolize? Because it reduces the intraoperative blood loss and it allows the tumor to be far more resectable than it would otherwise be. You do it for known hypervascular tumors like renal cell cancer, thyroids, sarcomas, neuroendocrine tumors. MRIs which show flow voids, hemorrhage within the tumor tissue, or bright post-contrast enhancement should be embolized. Typically, I like to embolize 24 to 36 hours before the surgery, and so that we can check the neurology before the patient goes back. Sometimes the edema created because of tumor necrosis can cause a worsening of the neurology, and you should be aware of that. The next step is excision of the tumor. We all know about tumor margins. You can go intralesional, you can go via marginal margin, a more radical margin, and a wide en bloc margin are things which you can do in order to excise the tumor. One of the common procedures we do is a piecemeal tumor excision. Here we can remove the tumor, either just debulking it or remove the entire tumor, but in a piecemeal fashion. So by necessity, this is an intralesional margin. And this leaves behind macroscopic tumor tissue and results in tumor spillage. There is a high risk of local recurrence and post-op radiation always needed. So this is a young boy, 30-year-old, who had a fibrosarcoma or osteosarcoma of the foot, and he had a metastasis to T5. A beautiful surgery was done elsewhere, where corpectomy was done and reconstructed. Unfortunately, the patient did not follow up with the treating surgeon, and radiotherapy was not given. Within a matter of weeks, he developed this huge recurrent mass all along the incision. The other method of treatment is an en bloc tumor excision. This can be done either through a marginal margin, a wide margin, or a radical margin. You are completely excising the tumor so that there is less risk of local recurrence, but this procedure has higher morbidity, a higher complication rate, but the advantage being that if you've managed to get a good tumor-free margin, post-op radiation may not be necessary. Step 3 is reconstructing the defect. As I said, 90% of the tumors involve the vertebral body. 80% of our body loads are borne by this anterior column of our body. Hence, the anterior defect needs to be reconstructed. There are many different options, autografts, allografts. The problem is that fusion takes time. And if you are going to give radiotherapy after that, fusion may not occur. And therefore, in my practice, I do not prefer autografts or allografts. I generally use a mesh cage filled with bone cement in order to reconstruct the spine. Nowadays, carbon fiber backed cages are being recommended, especially by the Italian group, in order to help radiation to be taken better. The fourth step is to restore the spinal stiffness. The area which is diseased undergoes abnormal loading, and there is movement at the site of instability. You want to recreate that stability, and for this multiple level fixation is necessary. You must remember that the challenge is in tumor is that there are often multiple adjacent vertebrae involved. There is disease-related osteoporosis, and disease continues even after you have removed the tumor. And therefore, there is always this quandary between doing too little and too much. The last step is post-operative radiotherapy. In the good old days, as I said, radiotherapy was the preferred treatment. And sometimes when it did work, they sent the patient off to surgery. The problems of surgery after radiotherapy is the risk of wound dehiscence, wound infections is far higher. Also, the chances of neurological improvement are lesser than if surgery was done before radiotherapy. And therefore, radiotherapy is preferably be started only after complete wound healing. In conventional external beam radiotherapy, you give it after about 3 to 4 weeks after the surgery. And with stereotactic radiotherapy, usually it is given 10 to 14 days after surgery. If you have used an autograft, you probably want to delay the radiotherapy for 6 weeks till some initial healing starts happening. So you are delaying what is vital to the patient, that is radiotherapy and systemic therapy. And that's why using autografts, allografts is not a great game. You would rather do some kind of other fixation. However, you must remember that all that we are trying to do is to improve the patient's quality of life. And therefore, the quality of life must be weighed against the surgical morbidity, mortality, and complications. Surgery traditionally has significant perioperative morbidity, a complication rate in the range of about 30 to 40%, and this has not changed. This is my study from 1991 to 1998, and this is a study which was done later by the same group in the 10 years, 2006 to 2016. You're seeing complication rate is essentially the same. If you look at the mortality rate also, it is essentially the same with all these things. So, there are limitations with surgery. And therefore, to overcome this morbidity, to reduce the complication rate, people are proposing minimally invasive spine surgery for the treatment of spinal tumors. It allows faster healing and it allows administration of post-op radiative therapy, which is the most essential thing, as early as possible. The types of minimally invasive surgery being done are vertebroplasty, kyphoplasties, percutaneous pedicle screw fixations, separation surgeries and endoscopic decompressions, and now you have radiofrequency and cryotherapy ablation of the metastatic tumor, following which you can do a vertebroplasty and stabilize this patient and give early SBRT. So here is one of my patients where we have done a vertebroplasty for multi-level pathological fractures in a patient with metastatic cancer. One of the new things which has come up is separation surgery. The traditional corpectomy involves a lot of surgery, lot of bleeding, loss of morbidity. So with the advent of SBRT, it was thought that if we can give radiotherapy without that morbidity, it would be ideal. So one does a surgery through a minimally invasive approach, debulks the tumor to create a zone of separation between the spinal cord and the area where radiotherapy needs to be given. That zone of separation has to be 2 to 4 millimeters wide, and then you can give stereotactic radiotherapy to ablate the tumor. The final step, now that we have discussed the treatment goals, the treatment options, is to decide what to do when. And there again the norms framework comes into being. The first step in the norms framework is systemic assessment. If your patient is very frail, lacks the will to live, then probably you don't want to do anything. If the patient is going to survive less than 6 months, just give palliative pain treatment. If patients have a short anticipated survival, less than 3 to 4 months, here you do palliative treatment for pain relief, do minimal access procedures, you can treat the patient with radiotherapy. Here is an example. This was a 73-year-old lady. The resident from Jaslo called me up, sir, there is a reference, this patient is there, she's got, she's got a tumor which is sitting at D7, she's got paraparesis and unable to sit, stand and walk, and he sent me the MRI by WhatsApp. My mouth was watering because I thought, yeah, ek surgery aa gaya. Then I went and saw the patient. In the middle of the night I went because I thought I have to do the surgery next day. When I saw the patient, he was cachectic and frail. Then I took the history and I found out the original was a squamous cell carcinoma which is chemo resistant and radio resistant. Then I realized that radiotherapy had already been done for all this previously. Then I found out that he had had an operation for the pathological fracture of the hip just 10 days back. And the bladder and bowel was incontinent for 1 day. So when a CT PET scan, which was done at the time of this hip surgery, showed multiple metastases all over. Therefore, a radio-resistant tumor, sin score of 6, which indicated a stable tumor, a Bilski, which is grade 3, which shows severe epidural spinal cord compression, but survival less than 6 months. I realized there was no point in operating. So I explained, the patients were very keen to get operated. They were very insistent. But I had to sit down and explain to them. And when I explained to them, they agreed to it. And I'm glad I didn't operate. 7 days later, this patient died. So the second step in the norms framework is instability of the mechanical type. The sin score, if it is less than 7, the spine is stable. In these patients, if the patient has pain because of a pathological fracture, then you can afford to treat this with radiotherapy because the pain is going to settle down over a period of time. If the score is between 7 to 12, indeterminate, radiotherapy may work, but the chances of radiotherapy failing are higher. And if the score is more than 12, this is an unstable spine which requires surgery. So here is a 71-year-old lady, a known breast cancer survivor, presented with severe neck pain. She was not able to turn in bed. She used to hold her head up when she would sit up, etc. And this has been going on during COVID for almost 3 to 4 months. You can see that there was an old pathological fracture of the C2 and a complete destruction of C2 over here. So in this was a classic patient with a radiosensitive tumor, but that radiosensitivity does not help mechanical instability. The sin score showed 13, which means it's highly unstable. Bilski was grade A, so that was not an indication for surgery. And Tokuhashi was 13 out of 15. The survival was more than 12 months. So I thought that this is a good patient to stabilize the spine and put the patient to chemo and radiosensitivity. And that's what we did. This is an X-ray, which is 8-month follow-up. You can see a nice fusion happening over here. The third step in the framework is the assessment of oncology and neurology. And here you have 3 types of tumors. Either the tumor is radiosensitive, chemosensitive, or it is not. If it is not, then you have to see, is it low-grade epidural spinal cord compression or high-grade epidural spinal cord compression? If it is a radiosensitive tumor, there are 2 types of tumor. There are solid tumors which are metastasis from solid organs. So breast, prostate, ovary, neuroendocrine tumors. These are radiosensitive, chemosensitive, but not exquisitely so. Here the treatment with conventional external beam radiotherapy is given provided ESCC is grade 0-1 and there is no severe deficit. On the other hand, there are cellular tumors, hematological malignancies, Ewing sarcoma, which are highly chemosensitive and radiosensitive. In these patients, the treatment is with CBRT, irrespective of the severity of the neurologic deficit. So here is a 15-year-old boy. Again, this is a boy who came during COVID with back pain, paraplegia, bladder bowel involvement since 12 hours. This patient had an Ewing sarcoma. And this was the size. You can see the entire left thorax was full of tumor. And there was a severe cord compression. But since this was an Ewing sarcoma, we know it is chemosensitive and radiosensitive. We decided to start the patient on chemotherapy to reduce the size of the tumor and make it amenable to radiotherapy. So we gave him 6 cycles of chemotherapy and lo and behold, the entire tumor has almost disappeared. At this stage, we put the patient on radiotherapy. Today, he is 2 years post the treatment and he is neurologically almost normal, though he does have spasticity, walking around, bladder recovery, etc. The second group is a radio-resistant tumor with low-grade epidural spinal cord compression. We know that conventional external beam radiotherapy is not very accurate. But if you give the lower dose of radiation, this is not tumoricidal. So the ideal thing is to give stereotactic radiotherapy, which is very accurate. But a lot of the centers in India do not have stereotactic radiotherapy. So in centers where stereotactic radiotherapy is not available, the treatment here is an aggressive surgical resection plus conventional external beam therapy. If you have centers where SBRT is available, then treat it with SBRT because you are not worried about radiation myelopathy in these patients. So here is an example. A left-sided nephrectomy done 1 year ago in 59-year-old male now comes with mechanical back pain because of a pathological fracture due to metastasis. The CT PET scan showed that this was the solitary lesion. You can see that this is a radio-resistant tumor. It is a stable, it is a partially unstable tumor, so in the indeterminate range. The Bilski grade is 1C, so potentially this is not a very severe cord compression. And Tokuhashi score is 13 out of 15, which means survival more than 12 months. In this patient, these were the days when we did not have stereotactic radiotherapy in our center. So we treated this patient with an R-block spondylectomy. We stabilized the spine in order to give the patient, and then put the patient on conventional external beam radiotherapy, and this patient went on to do well. He survived for 3 years before he eventually succumbed to his disease. Radio-resistant tumor with high-grade epidural spinal cord compression. If there is a high-grade epidural spinal cord compression, even the tightly focused beams of a stereotactic radiotherapy can cause spinal cord injury. And if you don't give enough dose to the edges of the tumor, there is a recurrence of the tumor at the edges. And therefore, in these patients, if the center has stereotactic radiotherapy, you think of separation surgery. That means you debulk the tumor, create a zone of separation, and let stereotactic therapy do its work on the radio-resistant tumor. If, however, stereotactic radiotherapy is not available, the treatment has to be an aggressive surgery. Does not mean that you always have to do a R-block spondylectomy. You can do a piecemeal, but try and do a complete resection as much as possible in these patients. So this is a 66-year-old male, non-small cell lung cancer on immunotherapy. The patient had lower limb weakness and was unable to walk. The PET CT showed multiple spinal metastasis. This is a radio-resistant tumor. It is a stable area of the spine, but there is severe cord compression, and the survival was less than 6 months. So we wanted to do the minimum in this patient. We went in and did a separation surgery and created a zone of separation through which a stereotactic radiotherapy was given, and patient did well till he eventually succumbed 9 months down the line. So to give you a final algorithm before I shut talk, and that is that if the patient has a metastasis in the spine, what I do is I first see, is this a stable spine or an unstable spine? If it is a definitely unstable spine, then it directly goes for surgery because you need to stabilize this patient. If it is a stable spine, the next thing you look is the epidural spinal cord compression severe or mild? If it is severe, then nothing is going to work. You need to do surgery. If it is mild, then you see, is this tumor radiosensitive or radioresistant? If it is radioresistant, then is SBRT available in your center? If yes, very good. If not, then go for surgery. So there are 3 indications for surgery: unstable spine, severe epidural spinal cord compression, and radio-resistant tumor in a patient place where SBRT is not available. If SBRT is available, you think of SBRT over here, and radiosensitive tumors with low epidural spinal cord compression, you can go for conventional external beam radiotherapy. What surgery? You have to decide whether your aim is long-term palliation. I think this curative word I have written is wrong. It's either long-term palliation or short-term palliation. Long-term palliation is contemplated in patients with solitary metastasis, with tumors which have a good survival, where patient is responding adequately to systemic therapies and patient is medically fit. A short-term palliation is contemplated in patients with multiple metastasis, patients with poor cancer histology, poor response to systemic therapies, and multiple medical issues. So before Dr. Srivastava falls off his chair where he's sleeping, I better stop. Thank you.